Pulmonary hypertension is an increase of blood pressure in the pulmonary artery, pulmonary vein, or pulmonary capillaries, together known as the lung vasculature, leading to shortness of breath, dizziness, fainting, leg swelling and other symptoms. Pulmonary hypertension can be a severe disease with a markedly decreased exercise tolerance such as heart failure. It was first identified by Ernst von Romberg in 1891. According to the most recent classification, it can be one of 6 different types. Signs and symptoms. Because symptoms may develop very gradually, patients may delay seeing a physician for years. Common signs and symptoms include shortness of breath, fatigue, non-productive cough, angina pectoris, fainting or syncope, peripheral edema, and rarely coughing up blood. Pulmonary venous hypertension typically presents with shortness of breath while lying flat or sleeping, while pulmonary arterial hypertension typically does not. A detailed family history is established to determine whether the disease might be familial. A history of exposure to drugs such as cocaine, methamphetamine, ethanol leading to cirrhosis, and tobacco leading to emphysema is considered significant. A physical examination is performed to look for typical signs of pulmonary hypertension, including a split S2 and loud P2 and sternal heave indicating a hypertrophied right atrium. Signs of systemic congestion resulting from right-sided heart failure are jugular venous distension, pedal edema, ascites, hepatojugular reflux, clubbing, etc. Evidence of tricuspid insufficiency and pulmonic regurgitation is also sought and, if present, is consistent with the presence of pulmonary hypertension. Causes and classification. A 1973 meeting organized by the World Health Organization was the first to attempt classification of pulmonary hypertension. A distinction was made between primary and secondary pH, and primary pH was divided in the arterial plexiform, veno-occlusive, and thromboembolic forms. A second conference in 1998 at Evian-les Bains also addressed the causes of secondary pH, and in 2008, the Fourth World Symposium on Pulmonary Arterial Hypertension was convened in Dana Point to modify the classification based on new understandings of disease mechanisms. The revised system developed by this group provides the current framework for understanding pulmonary hypertension. The system includes several improvements over the former 2004 Venice classification system. The Dana Point 2008 updated clinical classification system can be summarized as follows. WHO Group 1, Pulmonary Arterial Hypertension, Idiopathic PAR, Heritable BMPR2 ALK1, Endoglin, unknown drug and toxin induced, associated with connective tissue disease, HIV infection, portal hypertension, congenital heart diseases, schistosomiasis, chronic hemolytic anemia, persistent pulmonary hypertension of the newborn. WHO Group 1, pulmonary veno-occlusive disease and/or pulmonary capillary hemangiomatosis. WHO Group 2, pulmonary hypertension owing to left heart disease, systolic dysfunction, diastolic dysfunction, valvular heart disease. WHO Group 3, pulmonary hypertension owing to lung disease and/or hypoxia, chronic obstructive pulmonary disease, interstitial lung disease, other pulmonary diseases with mixed restrictive and obstructive pattern, sleep disordered breathing, alveolar hypoventilation disorders, chronic exposure to high-altitude developmental abnormalities. WHO Group 4, chronic thromboembolic pulmonary hypertension. WHO Group 5, pulmonary hypertension with unclear multifactorial mechanisms, hematologic diseases, myeloproliferative disease, removal of the spleen, systemic diseases, sarcoidosis, pulmonary Langerhans cell histiocytosis, lymphangioliomyomatosis, neurofibromatosis, vasculitis, metabolic disorders, glycogen storage disease, Gaucher disease, thyroid diseases, others, tumoral obstruction, fibrosing mediastinitis, chronic kidney failure on dialysis, pathogenesis, Whatever the initial cause, pulmonary arterial hypertension involves the narrowing of blood vessels connected to and within the lungs. This makes it harder for the heart to pump blood through the lungs, much as it is harder to make water flow through a narrow pipe as opposed to a wide one. Over time, the affected blood vessels become stiffer and thicker, in a process known as fibrosis. This further increases the blood pressure within the lungs and impairs their blood flow. In common with other types of pulmonary hypertension, the increased workload of the heart causes hypertrophy of the right ventricle, making the heart less able to pump blood through the lungs, ultimately causing right heart failure. The right ventricle is normally part of a low-pressure system, with pressures that are around 1/6 of those that the left ventricle normally encounters. As such, the right ventricle cannot cope as well to higher pressures, and although hypertrophy of the heart muscle helps initially, it ultimately leads to a situation where the right ventricular muscle cannot get enough oxygen to meet its needs and right heart failure follows. As the blood flowing through the lungs decreases, the left side of the heart receives less blood. This blood may also carry less oxygen than normal. Therefore, it becomes harder and harder for the left side of the heart to pump to supply sufficient oxygen to the rest of the body, especially during physical activity. Pathogenesis in pulmonary hypertension owing to left heart disease is completely different in that constriction or damage to the pulmonary blood vessels is not the issue. Instead, the left heart fails to pump blood efficiently, leading to pooling of blood in the lungs and back pressure within the pulmonary system. This causes pulmonary edema and pleural effusions. In hypoxic pulmonary hypertension, the low levels of oxygen are thought to cause narrowing of the pulmonary arteries. This phenomenon is called hypoxic pulmonary vasoconstriction, and it is initially a protective response designed to stop too much blood flowing to areas of the lung that are damaged and do not contain oxygen. When the damage is widespread and prolonged, this hypoxia-mediated vasoconstriction occurs across a large portion of the pulmonary vascular bed. In chronic thromboembolic pulmonary hypertension, the blood vessels are blocked or narrowed with recurrent blood clots, and these clots can lead to release of substances that cause the blood vessels to constrict. This combination of blocked or narrowed vessels and vasoconstriction once again increases the resistance to blood flow, and so the pressure within the system rises. Molecular pathology. The molecular mechanism of pulmonary arterial hypertension is not known yet, but it is believed that the endothelial dysfunction results in a decrease in the synthesis of endothelium-derived vasodilators such as nitric oxide and prostacyclin. Moreover, there's a stimulation of the synthesis of vasoconstrictors such as thromboxane and vascular endothelial growth factor. These results in a severe vasoconstriction and smooth muscle and adventitial hypertrophy characteristic of patients with PAH. In normal conditions, the nitric oxide synthase produces nitric oxide from L-arginine in presence of oxygen. Adenylate cyclase and guanylate cyclase are activated in presence of nitric oxide, and these enzymes produce CAMP and cGMP respectively. The cGMP is produced by a type of guanylate cyclase, the soluble guanylate cyclase, that catalyzes the formation of cGMP from GTP. SGC is a heterodimer made up of one alpha subunit and one beta subunit in each chain. It also contains a prosthetic heme group, required for NO binding. The union of NO and SGC produces a conformational enzyme change that stimulates cGMP production. In the vascular endothelium, cGMP activates cGMP kinase or PKG, which is an enzyme that belongs to a type of serine, threonine, specific protein kinase. PKG is a dimer composed of two similar polypeptide chains that share a common molecular structure. Each subunit contains a catalytic domain and regulatory domain. GMP kinase activates potassium channels and subsequently the inhibition of calcium channels. Thus, this process leads to a reduction of intracellular calcium and finally of vasodilation. Phosphodiesterase type 5, which is abundant in the pulmonary tissue, is a metallohydrolase that hydrolyzes the cyclic bond of cGMP in the presence of divalent cations. Actually, zinc 2+ union is necessary for PDE5 activity. In the N-terminal region of PDE5 there is an amino acid sequence that joins cGMP. This sequence of PDE5 is divided in two domains, GAFA and GAFB, but only GAFA has the necessary affinity to bind cGMP. This union increases the catalytic activity and it is stabilized by a close serine phosphorylation. Consequently, the concentration of cGMP decreases and the vasodilation is stopped. Patients with PAR produce less NO and others vasodilators and produce more vasoconstrictors. Consequently, this molecular pathway doesn't work properly and it results in a constant vasoconstriction. For this reason, NO and PDE5 inhibitors such as tadalafil or sildenafil are possible therapies. Tadalafil, for example, causes a vasodilation mediated by nitric oxide in the pulmonary endothelium. Diagnosis. Because pulmonary hypertension can be of 5 major types, a series of tests must be performed to distinguish pulmonary arterial hypertension from venous, hypoxic, thromboembolic, or miscellaneous varieties. Further procedures are required to confirm the presence of pulmonary hypertension and exclude other possible diagnoses. These generally include pulmonary function tests, blood tests to exclude HIV, autoimmune diseases, and liver disease, electrocardiography, arterial blood gas measurements, X-rays of the chest, and ventilation perfusion or VQ scanning to exclude chronic thromboembolic pulmonary hypertension. Biopsy of the lung is usually not indicated unless the pulmonary hypertension is thought to be due to an underlying interstitial lung disease. Further, lung biopsies are fraught with risks of bleeding due to the high intrapulmonary blood pressure. Clinical improvement is often measured by a 6-minute walk test, i.e., the distance a patient can walk in 6 minutes. Stability and improvement in this measurement correlate with better survival. Diagnosis of PAR requires the presence of pulmonary hypertension. Although pulmonary arterial pressure can be estimated on the basis of echocardiography, pressure measurements with a Swan-Ganz catheter through the right side of the heart provides the most definite assessment. PaOP and PVR cannot be measured directly with echocardiography. Therefore, diagnosis of PAR requires right-sided cardiac catheterization. A Swan-Ganz catheter can also measure the cardiac output, which is far more important in measuring disease severity than the pulmonary arterial pressure. Normal pulmonary arterial pressure in a person living at sea level has a mean value of 8 to 20 mm Hg at rest. Pulmonary hypertension is present when mean pulmonary artery pressure exceeds 25 mm Hg at rest. Mean pulmonary artery pressure should not be confused with systolic pulmonary artery pressure, which is often reported on echocardiogram reports. A systolic pressure of 40 mm Hg typically implies a mean pressure of more than 25 mm Hg. Roughly, MPAP equals 0.61 SPAP plus 2. Physical examination. A physical examination is performed to look for typical signs of pulmonary hypertension. These include altered heart sounds, such as a widely split S2 or second heart sound, a loud P2 or pulmonic valve closure sound, sternal heave, possible S3 or third heart sound, and pulmonary regurgitation. Other signs include an elevated jugular venous pressure, peripheral edema, ascites, hepatojugular reflux, and clubbing. Echocardiography. A meta-analysis of Doppler echocardiography for predicting right heart catheterization reported a sensitivity and specificity of 88% and 56%, respectively.